Good morning, welcome to our OCT peer review group. I'm very pleased to see you all. Before we just start, I'd just like to get everybody to just give us our name and to give us some idea about how much experience you have in interpreting OCTs. It should be a nice mixed group, and just to remind you that we should really all share in the discussion and to get as many ideas as possible from each other. So if I start with the other side.
So my name's Ian, and we've just acquired an OCT machining practice, but I'm yet to use it. So my knowledge of OCT is limited to what I've gleaned from articles and textbooks.
My name's Kerry. We've had an OCT in our practice for a little while. We don't use it on every patient by any means, so I have limited experience with it.
I'm Paul. I have an OCT. My role here is to facilitate the discussion rather than to participate in. So my knowledge is irrelevant.
My name's Dilesh. I'm a relative novice at using an OCT. We've literally just had one in practice over the last couple of weeks. We'll be looking into
My name is Suresh. We've just acquired an OCT in the practice. I've played with it. I've got very little experience in knowing what it means or what it says or which layers do what, and I would love to learn more.
Well, that's absolutely brilliant. So most of us haven't had huge experience, and I don't think that will matter at all in terms of interpreting what cases we brought for you.
First case is a 50-year-old male with sudden onset of blurred vision, altered colour perception and micropsy or small images, and things get better with a hyperopic correction. Stellar acuity is down in the right eye to 618 with normal vision in the left eye and normal intraocular pressures. He's self-referred because he's now noticed his vision is affecting his ability to work and to drive. He's a contract engineer, so we should expect him to be a reasonably confident and reliable witness, and he's generally fit and well.
If we could start off just having a look at the OCT images and then just get some discussion going about what you think you see. So if somebody would like to have a look at the OCT image and tell the group what they think they're looking at.
Well, there appears to be an elevation of the sensory retina from the pigment epithelium. So this could indicate a central serous retinopathy.
So has anybody else got any further comments?
On OCT, I see a bump and a red bit in the middle, which tells me that there is a bump and it's raised. Going away slightly from the OCT, he's 50 years old, fit and well, hopefully, probably a type A personality. I'm making it up now, I think. But the clincher for me is the suddenness of the onset and that he improves with hyperopic correction and altered colour perception and micropsia. So central serous chorioretinopathy looks like the plan. However, going down the list a little bit, differential diagnosis starts to worry me. And I'm thinking, can I really handle this patient? So obviously not. So I'd be starting to worry about other things similar to central serous chorioretinopathy that this could be.
Okay, has anybody else got any other observations?
Looking at the fundus reference image, is certainly a round greyish lesion of some sort, which would be consistent with what you're suggesting, central serous retinopathy. So using that as well as the fact we have a raised area very centrally in the macula, I wouldn't disagree with that diagnosis at all myself. And as you say, with the age the gentleman is, he's a contract engineer, probably quite busy and rushing about, and I think that sounds consistent.
That's good. Should we have a look at the fundus image? Do you think that the fundus image is kind of completely consistent with the OCT image?
Yeah, it definitely looks like central serous retinopathy on the fundus image.
Okay, what other things could it be, do we think?
It could be wet macular degeneration as well, couldn't it?
The actual fundus picture, the pigment's uneven. Just slightly to the right of the obvious grey lesion, there's quite uneven pigmentation there, which could be significant as well.
Okay, what do you think that could be then?
Well, it looks like I would have assumed that the retinal pigment epithelium is just uneven or disrupted. But then looking at the OCT image, it's not particularly, to me.
No, but the OCT image doesn't necessarily show all of those areas.
Sure.
What about the bit just a bit below?
I wonder if there are some drusen on the side there as well, which would be consistent with age, possibly smoking, but we don't know that.
Yeah.
So, does everybody agree that this is something that they don't want to manage in practice, or would anybody think we could be managing this in practice?
No, I think that definitely needs to be referred to the hospital.
Yeah, although if we're right about the diagnosis, the likelihood is they're not going to do anything about it. We need to be very, very certain about that diagnosis, and I don't think we really are.
Okay, let me just bring you back to start with. If we're going to refer this patient, how urgently would you suggest that this patient should be referred, and how will you go about managing that referral? Has anybody got a view?
I think that presents a dilemma. If you're confident about the diagnosis, then the condition is likely to self-resolve. But if there's the potential that it's something else, like a wet AMD, then the referral track would be very different. So it is an interesting dilemma, I think.
And what would your view be? Because it would all really depend on our individual experience as to how we approach that then. So what would you be inclined to do?
I'd be inclined to refer as a soon referral.
Soon for via the GP or direct to the hospital?
Through the GP.
Through the GP. Has anybody got any other views on that?
I would also go for a soon referral via GP, because my confidence on differential diagnoses, some of which we may not have picked up, is not the highest. So I would probably still go for a soon referral. I'm fairly confident this isn't a wet macular degeneration, because it doesn't tick the boxes for me.
That's exactly the same, yeah. Definitely refer it via the GP soon. And I wouldn't put it through a wet AMD fast track.
Right. What was your view?
In my area, we've got two choices. We've got the fast track, fax them to wet AMD service, or we have direct referral to hospital. And actually, unless it's pick up the phone and send them straight in, there isn't any in between. And I think I'm not seeing any hemorrhaging. I think I would probably send it via my direct referral, but not in the fast track wet AMD faxed service.
Saying that, if I didn't have the OCT image, I'd send it via a wet AMD referral, because I wouldn't be too sure.
It would be more difficult to make a diagnosis, wouldn't it?
Yeah, so without the OCT, I wouldn't be able to tell.
I think the useful thing is if you can send the OCT images, then the person on the other end can at least triage it slightly more effectively, maybe.
Yeah, that's a
could be
really
an
good
idea.
point.
Yeah.
Would anybody think of just calling their local ophthalmologist and discussing it? So that's one option.
It's not something that I've ever done. I'm not sure how successful that would be to pin down the right person, busy people, and get that opinion. I guess that depends on your relationship with the local ophthalmologist.
So the consensus is probably refer through the GP.
In this area?
In this area. Well, we know that this patient's acuity is improved if we give them a little bit more plus. Would anybody prescribe on a temporary basis to allow this patient to cope better?
Having looked at some diagnosed central serous retinopathies in the past, their resolution time seems to vary.
It does.
So based on that, it would depend on how desperate that person was for a resolution. My feeling would be not to prescribe anything unless it was made to, because of circumstances or work, knowing that this prescription will change again in the short term.
Yeah. Has anybody heard any of the literature on this, which suggests, particularly, I think you mentioned the type 1 personalities, in those individuals, reducing the stress by improving the vision often improves the outcome. Has anybody come across
No,
that?
interesting.
I haven't
as an option.
No. If he was a contact lens wearer, it'd be very easy to alter things. But I suppose it depends on his spectacles and whether he's willing. It's certainly worth discussing and letting him choose.
But I wonder if that raises an allied point about getting the patient to consider managing their stress levels themselves. Is that a discussion that we ought to be having with these patients? Is that likely to have some impact on
I'm wondering about the
recurrences?
correlation between stress and CSR. having seen some patients with CSR, I'm not 100% convinced. And I haven't got any data, because it's very easy to jump to stress and say, oh well, it must be stress. But I haven't seen any data. I'd love to see this paper.
It's certainly interesting to discuss it. Has anybody else noted patients who are particularly stressed in this condition? It is associated in the literature quite a lot, isn't it?
Not in practice, no.
Yeah, I haven't seen one for a long time, and I don't particularly know whether that patient was stressed out or not.
Stress related. Okay, so we've decided that central serous retinopathy, and we're going to refer in a timely way, but through the GP for onward management. We're not necessarily going to prescribe plus lenses for this patient, but we perhaps might consider it under certain circumstances. Do you know what sort of investigations they're likely to do when they get to the hospital?
My suspicion is they'd probably repeat the OCT, and they'd probably want to do a fluorescein angiography for this patient. Once diagnosis is agreed, then it's just a waiting game, really.
Okay.
If that was the diagnosis that was agreed.
And what's the implications for us as optometrists in practice, where you've got a patient who's unhappy with their vision? Do you think the patient could come back in between time dissatisfied, asking for your help? And in which case, what do you think you might do?
Well, I've had people who are interested from their own point of view to see how something's getting on, and actually they might come back and say, well, can you do it again, and we can compare and see if it's getting any better. And sometimes it's quite useful if they think it's getting better to OCT them again and say, yeah, just reassures people a little bit.
One last thing then on this case, if we can. Would anybody like to comment about whether this is actually something that's been going on for a little while, or whether this has been a very acute presentation, something that's suddenly happened?
I suppose it is arguable that instead of being a sudden reduction in vision, it could be a suddenly noticed reduction in vision. In other words, it could have been around for some time and you just noticed it, maybe covered one eye or looked through a camera or whatever. So I suppose that comes into the differential diagnosis and causes a bit of cause for concern.
Is there anything on the images that we've provided that might make you make that decision?
There may well be, but I haven't got the knowledge to interpret that. My experience of looking at OCTs, there may be some subtle signs that would tell us that, but I wouldn't know what they are.
Has anybody else got that experience? We're relatively an experienced group, so
Not enough to say much more than either side of the obvious lesion. You've got quite a nice photoreceptor line, and it elevates and it becomes slightly white and thicker in the middle, and then comes back down again. And I don't know whether that is an indication of how long-standing something is or not.
would it necessarily alter your management if you couldn't make that decision?
Probably not.
I don't think so.
Probably not.
Yeah.
I think from the symptoms we've decided it's sudden onset, and I would treat it as such for that reason.
Okay, good. Thank you.
When it comes to assessing OCT images, start with the basics. So you're provided with a fundus reference image. Look at that. It's a familiar image. You're used to doing fundoscopy, so let's start with a familiar image. Now, this is an infrared reflectance image, and we'll pick up a number of changes very effectively. It picks up fluid within the retina, underneath the retina or underneath the RPE, and it'll pick up pigmentary change within the RPE. Now, there's a clearly circumscribed oval lesion visible, which is likely to be an area of serous elevation, so subretinal fluid, and there's mottled absorption of the infrared light, which is likely to be RPE pigmentary change. The OCT clearly shows an area of subretinal fluid, both on the horizontal and the vertical cross-section, and the retina looks relatively normal apart from that, apart from being displaced. So the question we need to ask ourselves is this a normal configuration? Clearly not. So what's been affected? Well, there's clearly been a breakdown in the blood-retinal barrier. So where or what structures compromise the blood-retinal barrier or compose the blood-retinal barrier? So we're looking at either the retinal capillary bed or the inner border of the retinal pigment epithelium. So which do we think has been compromised in this case? Well, as the OCT cross-sections themselves, the neurosensory retina looks relatively normal, it's just displaced, it's likely to be the RPE that's been affected. So we're looking for an RPE defect. There's evidence on the fundus reference image, then a pigmentary change, which again would suggest that maybe the blood retinal barrier at the level of the RPE has also been compromised. The section that we'd taken out from the OCT volume scan, again, is trying to highlight a very subtle defect in the retinal pigment epithelium. Now, unfortunately, I've had the benefit of being able to see other investigations carried out for this patient, and I know exactly that's the location where the break in the blood retinal barrier is located. So in terms of what would be happening next for this patient in hospital, obviously we need to be thinking about further investigation. So fluorescein angiography would be an obvious next step, along with repeating the OCT, full fundus examination, perhaps fundus imaging, and obviously recording a detailed history of the patient as well as their visual acuities. The OCT map shows evidence of retinal thickening. Typically the central retinal thickness should be around about the 280 microns for the central subfield, and this patient is in excess of 400 microns, so clearly very abnormally elevated and thickened retinal structure on the OCT map. The fundus image, colour fundus image, again shows us an appearance which is probably typical of central serous retinopathy, and there seems to be a serous detachment and mottled RPE change is visible. What else do we have to be considering within our differential diagnosis? Well, this is a chap that is slightly older than we might expect, so therefore we can't eliminate an age-related cause for his reduction in vision. So we can't eliminate age-related wet macular degeneration. It could be idiopathic, of course, or secondary to myopia. So those are other things that we need to keep in the back of our mind, and then try and use the information that we have available to us to try and prove or refute our working hypothesis, which is one of central serous. So would we normally expect good visual acuity in a patient with wet macular degeneration? No. They're often complaining of distortion of vision. Again, our patient's not complaining of distortion. So these are sort of marks against it being choroidal neovascularization as a possible cause, but we can't be absolutely certain. But we've kind of narrowed our differential diagnosis a little bit. Now, is there any evidence that this is perhaps an acutely noticed problem, or and not actually a genuinely acute presentation? If we look at the outer segments of the photoreceptors, they seem to be thickened and enlarged. And when we're thinking about normal photoreceptor physiology, the outer segments are shed and normally phagocytosed by the RPE. If the neurosensory retina is detached from the RPE, then that process cannot normally take place. So this area becomes infiltrated with macrophages, which try to absorb this waste photoreceptor material. If we then carry out fundus autofluorescence imaging, we'll find that actually we can see that this image shows a hyperfluorescent region within the neurosensory detachment, and these are basically lipofuscin-rich macrophages that are being imaged using the autofluorescence procedure. So again, this implies that this is actually a long-standing problem. The thickened outer segments of the photoreceptors appearing like stalactites again imply chronicity. So when actually quizzed, this gentleman confessed to having actually had visual symptoms for several months, and he's simply too busy, too worried to actually do anything about it. And then when he came along, his symptoms were actually beginning to resolve, although he was still visually symptomatic. Fluorescein angiography obviously is a useful investigation in terms of hospital investigation of the patient, and it allows you to identify an active area of leakage, and also identifies where the leak is if you're thinking about invasive laser therapy as a possible treatment for the patient if they've got a chronic presentation. In terms of simple investigations that can be carried out then in optometric practice that would help you narrow the diagnosis, enhanced depth imaging of the choroid using OCT is extremely useful, in that if you see thickened choroid in the presence of subretinal fluid, it's more likely to be associated with central serous retinopathy. Patients with age-related macular degeneration often have a very thin choroid by comparison. So thickened choroid, you should start to be thinking more likely to be central serous. How thick is this? Well, this patient's choroidal thickness at the centre is around about 530 microns. A normal subject will be around about the 205, 206 micron level. So this patient has got a grossly thickened choroid. So again, more evidence to support the fact that this is likely to be central serous retinopathy. Autofluorescence imaging, again, is valuable. It allows you to assess the integrity of the RPE and how widespread any RPE changes might be, and also it allows you to identify evidence of long-standing presentation. Should you refer a patient with central serous retinopathy on or consider monitoring them in practice? Well, central serous retinopathy is not a benign condition. If left unchecked, you can end up with widespread photoreceptor and RPE atrophy, as shown in the image here. Again, the autofluorescence image shows widespread RPE changes, and you're also seeing atrophy on the RPE map, and the OCT cross-section is clearly abnormal. So, in all cases, consider referring on, particularly if you cannot eliminate the possibility of another cause for the subretinal fluid. An elderly lady with sudden loss of central vision with a history of fluctuating vision for some weeks. Visual acuity is now reduced significantly, and as you might expect of somebody of this age, their blood pressure is not as good as it might be, and they've also got some elevated cholesterol. But that in itself is not particularly significant in terms of the ocular findings.
So let me introduce our next case. This is a 71-year-old lady who is not very good at giving a history at all. Her general health is not too bad, but she's been treated for high cholesterol and raised blood pressure. She's retired now, but she presented with sudden loss of vision. In the clinic, she measured 636 in the right eye with 6.6 in the left eye. We were unable to get IOP measurements for her, and she reports that although the loss was sudden, she'd noticed it change over the last few weeks. So she hadn't seen anybody else about this problem, but she would like your opinion as to what's going on. If we have a little look at the OCT images, would somebody like to give their thoughts on what's going on here?
It looks like a full thickness macular hole, perhaps secondary to vitreomacular traction, which would certainly account for the poor vision in the right eye.
Right. Do you think that might also account for the suddenness of the loss of vision and the further deterioration?
I think it could explain that. If the traction was happening, then that could cause a gradual escalation of visual changes, and then when the full hole develops, then that accounts for the sudden loss.
Does anybody observe anything else in those images other than just a full thickness hole?
We've got some cysts and intraretinal cysts as well. The retina's elevated either side of the hole with some cystic changes within it. And you can see on that posterior vitreous interface there's a little piece in the middle as well. There's probably a bit that's come off.
Okay, that's come off, yeah.
To me, she looks the ideal candidate for a macular hole because female, over 60, sudden loss. She's got quite a few, look to me like drusen around in the macular region. From the fundus photo, it looks like a very classic macular hole. I feel she's almost out of a textbook, but I don't know the whole of that textbook, in case there's something else going on that I'm not sure about.
Okay, so the fundus signs you think support the OCT signs and support Ian's view then?
Absolutely.
So would you have any differential diagnoses, or are you completely clear?
If this condition had been there, it says it's sudden loss of vision, so it's obviously not been there very long, but had it been there many, many months, I probably would not gain very much by referring this patient. However, if it's a relatively new macular hole, then she could be available to have some treatment for this.
Right.
But the cut-off point, I believe, in some places is 6 months and some 12 months. But generally speaking, if it's less than 6 months, then she could potentially have treatment, because there is a risk the other eye could have the same thing as well in the future.
So would anybody else agree with that view, that you'd refer her given the circumstances?
Given this fairly recent presentation.
And how urgently would you do so, do you think?
Wouldn't be urgent. It would be more soon to routine, I would have thought, because it's not going to get any worse.
Right.
But as a precaution, you want to make sure that they look after the other eye.
Right. And nobody would just monitor this in practice?
No, I'd definitely refer as well. because there are treatments available. I'm slightly worried about the other eye because it's 6/6, and usually if you have a macular hole in one eye, the likelihood is it might well happen in the other, and can we actually get this before it happens? We haven't got the OCT images of that left eye. It'd be useful to know if there's some traction going on there, or it might give us clues as to what happened in the right eye as well.
Yeah. And so you'd want the OCT image, the other eye for sure?
Yes.
Yeah.
Even though she's got good acuity, it may look fine with an ophthalmoscope, but yeah, it'd be lovely to see what's going on there.
On a side note, would they monitor that at the hospital then for the left eye in subsequent appointments? Does anyone know? Just to make sure that it's not going to go? Or would they just see it once and say it's probably not and then discharge her back to practice?
If the decision was made that she has got a macular hole and she could opt for not having treatment because she doesn't want to have treatment because it's not particularly nice, especially the posturing part, it's very uncomfortable. So she may decide not to have it. If the other eye, following OCT, showed that she's already had a posterior vitreous detachment in that region, her risk of getting a macular hole in the good eye is pretty low. So following OCT, which I go with Kerry, that it would be nice to see the other OCT, would be able to estimate whether the other eye is at risk or not.
What happens when if we have the other eye that shows that there is early signs of vitreomacular traction on that eye? Would that alter your approach, or do you feel differently about it?
As far as referral goes, I would still refer, because I don't feel that this is an optometric issue. This is a medical retina or an ophthalmology issue. So the final decisions should be made by an ophthalmologist by virtue of the exact diagnosis, possible differential diagnosis, and risk to the other eye.
Maybe we could just spread this discussion just for actually on this case. If it turned out that the left eye had a vision of 6/9 and there was definitely macular thickening on the OCT due to traction, would that alter the management that the ophthalmology team might have, and therefore the advice that you might be giving her in terms of what to expect? Does anybody...
There are treatments now to attempt to dissolve the tractional forces with a drug. So it'd be perhaps wise to tell the patient, and comforting perhaps to tell the patient, that there are treatments for this in the fellow eye.
Do you know how that treatment's administered? Does anybody...
I didn't know there was such a thing.
It's injection. Jetria.
Is that ochraplasmin?
Yeah, ochraplasmin. That's the generic name.
Jetria.
If that were to be offered, are there any potential risks to the patient?
Well, with any intravitreal injection, now I'm hearing about it, there's always a risk of possible infections, possible macular edema, possible retinal detachments.
I'm not sure it's an easy fix, as easy as it sounds, and I can't say I've actually had anyone actually had it done yet, so I've not heard any feedback from patients. I have had patients who've had surgery for macular hole, some of which have been quite successful and improved acuity, and hole seems to have closed quite nicely. But yeah, I think with Jetria being quite a new treatment, there's always going to be some risk involved, isn't there?
No, I was just thinking if the right eye definitely got a full thickness hole with very poor acuity, and the left eye, the acuity was reducing because of traction, whether intervention would be a good idea or not a good idea under those circumstances, because there would be a risk of the left eye getting a full thickness hole, which would devastate this patient's vision.
I'm not really absolutely sure about the risk factors. So I think before making any decisions, before worrying the patient, adequate checks should be made, and then discussion carries on from there on.
Does anybody think there'd be a chance in that hypothetical case of the little bit of traction on the left eye that it will self-resolve? Could it?
Yeah.
It can do.
Yeah.
If you get a nice clean break from the vitreous and the retina, then yeah, nothing may come of it.
You might tap down and just be all right.
Sort of decision you need an ophthalmologist to make,
yeah,
rather
it's
than an
not-
optometrist, really.
Out of our comfort zone.
Very much so.
If I put the literature to one side, which I don't know very well anyway, And if I think of the patients that who've had macular holes, of which there are many, I cannot remember a bilateral macular hole. I can't remember one. I'm trying.
I have a patient who presented with a full thickness bilateral in both eyes, and the VA was down to 6/36/24 when I saw him. But he was referred. He's got a little bit back. He's had treatment in both eyes, surgical treatment on both eyes.
It's a bit scary though.
It's all about the pros outweighing the cons, isn't it? With any ocular surgery, as always.
Okay, good. Well, I think that's excellent. Thank you very much.
The fundus reference image shows a clearly circumscribed donut-shaped lesion centrally, and the OCT cross-section shows a full thickness retinal defect with retinal cystic change either side of the macular hole. There's evidence of a posterior vitreous detachment and a central operculum, or a piece of retinal material that's been pulled away. So the changes we see here result from vitreomacular traction. The OCT map shows central retinal thickening, as you might expect. And the fundus image again shows a clear cuff of edema and a full thickness retinal defect. The autofluorescence image shows an unattenuated central hyperfluorescent area, which corresponds to the full thickness retinal defect and the loss of macular pigment, which normally attenuates the autofluorescent signal at the central fovea. Patient needs to be referred on to hospital eye services for possible surgical intervention. In terms of urgency of the referral, that will largely need to be guided by your local referral policies. We need to be thinking about the fellow eye. The vision in the fellow eye is good at the moment, but does the patient have vitreomacular traction in the other eye? If they're asymptomatic and their vision is good, but there's evidence of vitreomacular traction, then really there's nothing to do other than to monitor the patient to see if things progress. If the patient is visually symptomatic and there's evidence of vitreomacular traction, then a referral to hospital eye services may be indicated for the fellow eye. A 69-year-old gentleman with deteriorating vision that's been deteriorating for some time. He's noticed deterioration over the last year or so. He's got some central schistomas and some amsler distortion. Vision is certainly reduced, 6/24 and 6/18 in both eyes. Self-referred, he's known to be a smoker and he consumes a moderate amount of alcohol each week, and not unsurprisingly, he's retired.
This is our next patient. He's a 69-year-old man who had has a history of dry age-related macular degeneration. He's retired. When we saw him, the presentation was 6/24, 6/18, and he presented with a history of deteriorating vision, particularly just worsening over the last 12 months. And there's some history of central scotomas and some distortion on amsler. He presented just routinely for a normal refraction following a reminder letter.
Some extensive focal disruption to the RPE. Perhaps that's just the reflection of the drusen that's causing that extensive drusen that you can see.
A few things that come to mind. First of all, he's obviously got dry macular degeneration. He's relatively young for this quantity, and I wonder if there's a familial element or a lifestyle element as well.
No, you think of anything particular?
I'm going to familial drusen.
Familiar drusen. Is there anything else that might come to mind then?
Perhaps a smoker for many years, that's a possibility. But the other thing is that over here on the OCT we've got a line OCT, and there is a possibility with deteriorating vision that there could be a wet element here, and perhaps a more extensive OCT may be a better idea.
Okay, is there anything in the images that are provided that might make you suspicious of that?
In the fundus photo, I'm not sure if I'm looking at the choroidal vessels underneath, or I'm wondering if I'm missing any hemorrhaging anywhere, because I may well be, and I'm starting to suspect that this person may actually have wet AMD underlying. I'm not sure about that.
Has anybody else got similar thoughts?
On that picture you've got brighter spots and you've got darker spots, so we've got two different kinds of pathology going on. They're not the same thing. If you look at the coloured picture, yes, they all look like slightly yellowy patches, but actually on the infrared there's a clue that there's two different kind of things going on. Same with the OCT, the appearance through that slightly shinier looking drusen looks different. It's not as a continuous RPE with a bump in it. We've got sort of a little bit more, as you call it, just disruption.
So we think this is age-related macular degeneration and maybe a few other things going on, possibly something familial. What will we do with this, bearing in mind this is just a routine visit and we don't really have available any details of his previous acuities at the last visit.
Do we know if he had a central scotoma or Amsler distortion last time we saw him?
I think he probably did, yeah.
Okay, fine, so that hasn't changed.
Some Amsler distortion.
Yeah, fine.
I want to play safe with this chap because in the back of my mind I know that dry AMDs can become wet AMDs. It looks a very busy picture as far as the AMD goes, and the fact that it's reduced and we don't have enough information on him, I'd possibly initially like to repeat the OCT to get more information from the OCT rather than rush to the referral pad.
Ken, you suggested that we could repeat the OCT, which I think sounds a reasonable idea. We agree. Over what period of time would you do that? When would you have him back to repeat the OCT?
Oh, the first OCT I would repeat straight away because it may be better to focus a little bit higher, a little bit lower, the absolute central part of the macula,
right,
to see if anything shows up from that.
And if you were still unsure, were there any consulting room tests that you might do to help you?
Or the one I love to do is pinhole.
Pinhole?
I like my pinhole.
And Amsler, you could issue the patient with an Amsler so they can monitor at home.
I mean, the inference from the case history is that he's come for a routine attendance, so we might be lucky enough to have an Amsler from previously, or a fundus image. So do you think, looking back at the records, that would be a guide to help us?
Okay.
Very much so.
What the vision was like last time as well.
I think I'd give him an Amsler, ask him to note if it gets worse at home, repeat the OCT in say a month or maybe even 6 weeks, probably a month. Just thinking about if I didn't have an OCT and I saw that appearance on the fundus, I wouldn't have thought it was wet. I can't see hemorrhaging, I can't see grey lesions suggested of fluid. I think it's just I need my OCT skills to be better in order to make a certain diagnosis that there isn't any leaking here. But if the fundus picture were all I had to work off, I would say that was dry AMD.
Yeah.
Okay, so can I just ask if you made that assumption, but there was just an inkling of a kind of, maybe you weren't 100% confident, would there be any advice that you could offer the patient to make sure that he knew what to do if there were changes, and what would that advice be?
Advice on diet control, improving his quality of food, possibly supplements, which is a bit of a 50-50 whether it will work or not. But his age doesn't seem to be conducive to his dry AMD. He's only 69, and his general health is good. I'm a bit worried about that as to why is this.
So
is his lifestyle so bad? It could well be.
Yeah, if we come back to that in a few minutes. But in terms of if you decided you were going to monitor him over the next month or two, would you give him any advice as to what to look out for in case things were changing? What sorts of things might he see?
Looking for distortion, so I think giving an Amsler chart for him to take home and monitor, instructing him appropriately on how to do that and how often to do that. And any changes, then he needs to contact the practice immediately, so he can be reviewed for OCT, and then any evidence of wet changes, then they can be fast-tracked.
Right, so just making sure he knows. Does everybody think that's a good...
Proper tuition on the Amsler grid as well, not just handing it to him and say, right, tell me if that goes a bit wobbly.
Reassurance that he should come back and he's not being a nuisance. He should see that.
And then documenting that all on the records, of course.
I usually try and tell people Just ring me. I'll decide if it's a problem or not, and I'll tell you whether to come in or not. Ring me if you think there's something wrong. I'd rather you came and saw me and it turned out to be okay, and than you leave it and it turned out not to be okay.
Okay. Can we just go back to your point, because you were you're quite not completely convinced that this is just a typical dry AMD, and even if you didn't suspect it was much different to before, you would feel that you might take a different approach.
The reason I'm uncomfortable is, first of all, there's not enough information about his lifestyle here. Also, his general health, it says, is not available. There's no information on medication. So really what we need for this patient is a little bit more information about him. His age is a concern to me, that he's only 69. So perhaps a bit more information would help to make a better decision.
And can I ask what sort of information the group thinks? Is there anything specific that you'd be looking for? Obviously, general health and medication.
Medication, smoking, lived in a hot country and is a very fair person, perhaps.
Family history.
Family history, obesity.
So
Quite a few considerations.
It's the sort of thing that you would expect to glean on a routine refraction anyway.
Yeah.
So we've been disingenuous by not giving you enough information. If I was just to throw into the mix a little bit of that information that you would expect to have, and tell you that he is in fact a smoker and has smoked for quite a lot of his life, would that piece of information lead you to do anything particular or offer any particular advice?
I would be very keen to discuss stopping smoking with him, and also it is possible to refer him on to various services run by public health locally to help him to stop smoking. But I would explain that there is no such thing as reducing smoking. You either smoke or you don't smoke. And it's an extremely painful thing to stop smoking, having done it for so many years. But in this particular case, I suspect it's necessary. Guidance is essential via various services, and that's where I would direct him to. We do have a scheme locally, which isn't used enough, called MEC, Making Every Contact Count, and that leads to giving information on stopping smoking.
Is everybody in the group aware of where they can get information about smoking cessation in their areas?
Not completely. I think I'd refer to the GP. I'd give them advice, and my opinion is the best thing you could do for your eyesight right now is stop smoking. I know that's easier said than done, and maybe offer to write to his GP about it. I would have thought they'd have access to those services, but I don't know, in my area we don't particularly have a known channel set up.
I don't know, Deanna, have you got...
I think perhaps there are channels and I don't utilise them enough. My advice normally extends only to giving up smoking and not really any further advice beyond that. And I know north of the border, I think colleagues I think it's a requirement, if I understand correctly, in Scotland that they must give advice as part of their eye examination.
Do you think as a group, or do we think that as a group it's part of our role to offer general lifestyle advice and to facilitate patients doing things like cessation of smoking and getting more exercise or what have you?
I think we have a duty to educate patients of modifiable risk factors.
And do you think we also have a duty to know what the services are in our area and how to access these?
I think it's essential. Public health themselves are struggling with various problems, but smoking cessation is very high on the public health list at the moment. The Coventry Council does have quite a lot of information on stopping smoking, so it doesn't really have to go by a GP. GPs are busy, optometrists are busy, so it's finding the right place to go to help them out.
Something we do have in our practice is a flow diagram produced by Aston University about dietary advice when you see macular changes, and it goes through whether there's drusen there or geographic atrophy, and you follow the flow diagram into the dietary suggestions or whether to suggest supplements. That's quite a useful actual tool.
Presumably there's plenty of information on the internet if you weren't sure what services were available. Would that be an option for optometrists to use?
Absolutely.
Yeah.
The negative thing is that if the person didn't stop smoking and decided to continue, and then we put them on dietary supplements, the connection between vitamin A and cancers could actually make them worse. So
have to be careful. The AREDS2 study threw up some useful alternatives to vitamin A.
That's good. Okay, thank you.
The OCTs, again, show a fairly clear change. The fundus reference image shows classical signs of large soft drusen, small hard drusen, and large confluent drusen. There's also a small area of RP atrophy which appears highly reflective on the infrared reflectance. The OCT cross-section again demonstrates changes that are confined to the outer retina. So we're looking at predominantly RPE disease. So we're seeing elevation of the retinal pigment epithelium, thickening of the retinal pigment epithelium. We're also seeing interruption of the ellipsoid, myoid and outer segments of the photoreceptors. And this is important because this will account for the patient's visual symptoms. And it's not really surprising that the patient's experiencing some distortion. So the key thing, I guess, then is, are the changes he's observing new changes? And if you're getting new distortion, then that might be more concerning. Again, some thickening on the OCT map, which is probably not unsurprising in view of the appearance that we're seeing. And again, vertical cross-section shows disruption to the photoreceptors and the RPE. The extracted image from the OCT map passes through one of the areas of high reflectivity on the infrared reflectance image, and this shows early onset RPE atrophy. So there's widespread pigment epithelial disease and early onset RPE atrophy in this patient. Concern is that the RPE atrophy may progress more rapidly, so it would probably be worth monitoring this patient and to assess the autofluorescence characteristics of the RPE over time, as that will give you a better indication as to whether or not the RPE atrophy is progressing. But again, OCT is still a useful technique in terms of monitoring the progression in this patient. The fundus image shows a classical appearance of age-related maculopathy, and the autofluorescence image again shows some areas of hypoautofluorescence consistent with areas of RPE atrophy. On-fast OCT again shows the distribution of the drusen very, very effectively, and as a technique is useful, I think, to engage the understanding of the patient and particularly the carers that may be working or responsible for the patient. Ongoing, if the RPE atrophy progresses and becomes larger, then a patient should be referred on to hospitalised services. Not that at the moment really there's anything that can be done in terms of treatment, although there are stage 3 trials now for drugs for geographic atrophy, but the diagnosis of GA needs to be made by an ophthalmologist, and then that will unlock social services and low vision services for the patient. Ongoing assessment of macular pigment, it may very well be important in the future, particularly in a prognostic factor, but also looking at the effects of smoking cessation, dietary modification and perhaps dietary supplementation. But as again, I think there's still more evidence to be gathered in terms of the efficacy of this approach.